So welcome to the panel, The Violence Against Women and Girls. Although it may be the last plenary session of the program, its importance cannot be underestimated, and it's why Stanford chose to sponsor this session. Nicholas Kristof, I don't know if anybody saw this yesterday, had a great op-ed piece in the New York Times about why Boko Haram actually attacked the girls' school in Nigeria. And I'm going to just end this with a quote, because I thought it was so powerful. Quote, "There is no force more powerful to transform a society than the education of one's girls. Thus, if you want to control your country, manacle your daughters." This is why I think this panel will be a very interesting discussion about some solutions to this. So let me introduce the moderator of the panel, Joy Fitzgibbon. Joy, want to come up? She is the Deputy Director of the G8 Research Group and a research fellow in the Global Health Diplomacy Program at the Munk School of Global Affairs in Trinity College at the University of Toronto. Her research in global health policy focuses on the marginalized and most vulnerable populations, exploring the impact of global health networks on how to reform policy. Joy.
Thank you. Thank you first to Dr. Michele Berry for such a kind introduction, and in particular to Stanford University for supporting and this panel here today. We're delighted to be here, and I can hardly wait to hear this panel of illustrious scholars who have so much to share with us. We were reminded at the opening plenary session, you may recall, of the Millennium Development Goal on women's equity, on gender equity, and that in fact we haven't met that goal and that we have a great deal of work left to do. This panel is really dealing with a critical aspect of that, of violence against women. As Michele just mentioned, the opening of their newspaper this morning on My Canadian News, there were two issues this morning on the plight of women who were victims of violence. One, of course, this horrible story coming out of Nigeria. The other to do with Indigenous Aboriginal Canadian women who find themselves vulnerable to abuse. And if statistics are correct, probably many of us in this room know somebody whose life has been affected by violence, often perhaps by an intimate partner. As a political scientist, there's always a danger that everywhere you look, you see politics. And one of the things that has struck me at this particular conference has been a repeated theme of the role of civil society, specifically the role of experts, scholars, non-governmental organizations in global health, and the need to engage in meaningful ways with governments and corporations to improve our responses to our various global health problems. And it seems to me that there are kind of three models we can think about when we look at violence against women and the relationship politically that can drive this process. And the first is a sort of model of critical individuals sort of standing at the sidelines. I call it the voice crying in the wilderness model, of criticizing maybe government policies or other policies that systematically marginalize women. The second is always the risk that when one works very closely, one's agenda is co-opted by whoever one partners with. And this was mentioned yesterday, actually, by Dr. Horton, who was concerned about certain types of relationships with the corporate sector. And that is also a legitimate concern. But the third politics is one that I would call the politics of critical partnership. And it's a politics that is essentially made up of activists and of scholars who are advocates who, in careful, objective, and intelligent ways, present information to governments and to other organizations working in these areas, social agencies, etc., to correct policies. And these are individuals who are adept at adapting their knowledge to satisfy the requirements of global policy at our international organizations, our national policies, as well as local policies, municipal type policies, and so that we can create scientific knowledge that's adaptable to the particular needs of women in these countries. So as I look at the illustrious panel to my left, it is not a coincidence that this particular panel is made up of scholars who in many ways have rich ties to community organizations, civil society organizations as scholars. Now, our panelists today are going to speak to us about the scope of the problem, the kind of 30,000-foot picture, as well as associations, driving associations with violence against women, as well as some of the best ways to respond to it, the kind of best practices of what is working and what is not in preventing violence against women. Specifically, we're going to hear about the latest epidemiological research around the global burden of disease. We're going to learn about recent evidence that identifies biomarkers in violence against women. We're going to explore the relationship between violence against women and violence against children. And finally, we're going to consider what's working and what's not in our prevention and response. Now, you'll be able to tell by what I've just said there that we've had just a couple of changes to the panel. Regrettably, Dr. Nima Abrahams is unable to be here. However, the great news is that Alessandra Gretis from the Pan American Health Organization has graciously stepped in, and she has some exciting work that she's going to be presenting from the work that she's doing there. And also, Dr. Sunita Kishore is going to be presenting a new study, an exciting study that they've just completed on biomarkers in violence against women. So we begin with Dr. Jacqueline Campbell. And to many of you, she probably does not need an introduction, but I'm going to give her a brief one anyway. Dr. Campbell is the Anna D. Wolfe Chair and Professor in the Johns Hopkins University School of Nursing. She has a joint appointment with the Bloomberg School of Public Health. And as many of you know, she has an illustrious career engaged in advocacy and policy work, particularly in the areas of intimate partner violence and health disparities related to trauma. And she's been conducting research in those areas since 1980. She's published more than 255 articles and 7 books on violence against women. She also is an elected member of the Institute of Medicine, the American Academy of Nursing. She co-chaired a steering committee of the WHO multi-country study on violence against women and women's health. She is immediate and past president and on the board of directors of Futures Without Violence. We look forward to hearing what you have to say, Dr. Campbell. Thank you.
Well, good afternoon. We are definitely the bringing up the rear panel. Here we go. And I am not getting it to go. Oh, it's amazing. Thank you. That's because I had the wrong thing. And I'm going to talk some about all of the evidence around intimate partner violence and health outcomes globally. And when we think about the burden of disease from intimate partner violence, we first have to think about mortality. And femicide has often been defined as the murder of women, and some define it in terms of the murder of women because the person is a female. It's to differentiate from murder of men because of the many different dynamics and risk factors. We also think about other forms of gender-based killings, honor killings, dowry burnings, that don't get included in most homicide statistics. And this is from the WHO World Murder Rates per 100,000. And you look at the areas of the world which have the higher murder rates. And the WHO website goes on to analyze this data. It says how many of these murders are murders of women, how many of them are murders of men. But then from there on, it aggregates the data and calculates the risk factors. And because there's so many more murders of men, the risk factors are all about male-on-male killing. There are things like gang violence, young men in peer groups that are violent, and does not take into account what happens with the murder of women. And one of the things it ignores is domestic violence-related deaths, homicides, suicides, children killed as part of those murders, and others who are killed. And so we, about a year ago, published in The Lancet looking at murder of women. The first thing to notice here is that there's huge swaths of the world where we really don't know how many women are murdered. And those are that pale yellow swaths of the world where we have no good data. That was the most troubling part of it. And then the dark colored areas where we know that we have substantial proportions of women who die, who are murdered. And so part of it is in terms of the proportion of intimate partner homicides among all male homicides. And those percentages are related to those parts of the world. And so we have in various places in the world, I mean, that's the other thing to note, that there's both low and middle income countries where we have high proportions of the murder of men being intimate partner homicides, the murder of women being intimate partner homicides. And we also have many different cultures where sometimes you would not expect there to be such high proportions when women are killed, that they're killed by intimate partners. So when we disaggregated by gender, we found only 66 countries of approximately 190 reporting homicides of women, especially whether or not they were intimate partner homicides. Where we do see that, we see 6 times higher for female homicides in terms of being killed by an intimate partner than males. So although males are killed more often in murder, it is relatively seldom that they are killed by an intimate partner. Where for women, it's most often the single greatest proportion are by intimate partners. When you adjust for unknown victim-offender relationships, we find 47.4% of female homicides are committed by a husband, boyfriend, ex-husband, ex-boyfriend, where we know in this world. And it's highest in high-income countries and in Southeast Asia, 2 very different cultural places where we really have to think hard about what are the dynamics that are similar and what are they the same. The only countries where the numbers of males killed by partners is equal to the number of women killed by partners is Panama and Brazil. Again, what's going on there? We need a lot more information about that. But particularly we need more information in those big parts of the world where we have none. So in summary, 1 in 7 homicides globally and almost half of female homicides are perpetrated by an intimate partner. And that goes up to 70% when do actual hand counts, and when you include ex-boyfriend, ex-girlfriend, which oftentimes does not get counted. It's the highest in Southeast Asia, high-income countries, and the Americas. And the African region comes very close, 40.1%. But you remember on that original map, there's big parts of Africa where we don't have the data. It's lower in the Western Pacific, low and middle income European countries, and Eastern Mediterranean countries. Again, very different cultures. What's happening? We need more information to be able to determine that. And the percentage of intimate partner homicides with male victims is highest in high-income countries, but still it's not very high. It's only about 6.3% of the homicides of men are by intimate partners. When we look at per capita femicide comparisons, we have very different ones depending on where we look. The only low and middle income country where we have good per capita estimates are in South Africa, where we have high rates of intimate partner homicide, and that data was collected in 2008. Actually, though, it had gone down per 100,000 since 1999, which was immediate post-apartheid. So again, interesting dynamics, what's happening in those countries, and important that we have those dynamics in order to do prevention of homicide, because that is the most lethal form of intimate partner gender-based violence. We find where it's counted that Indigenous women are at increased risk for femicide, and in general, and intimate partner femicide. We have a lot of missing women in, for instance, Northwest Canada, Indigenous women, but even so, we can count and we know that there's an increased risk. Intimate partner violence, wherever it is looked at, is the #1 risk factor for intimate partner homicide. So the majority of women who are killed by a partner or ex-partner have been abused before they were killed. So we've done a lot of work in this country around prevention of domestic violence homicide, that some of those lessons can be learned globally. Abused women oftentimes underestimate their risk of homicide, so part of it is to work with abused women in terms of helping them accurately determine, and also to identify and manage high-risk abusers. In the United States, we've had a pretty dramatic decline of intimate partner homicide of women. And that decline is mainly related to increased domestic violence laws and resources, and also gun removal from known abusers. And that's one of the things that started to happen in South Africa, which partially accounts for their decline in intimate partner homicide. Now, gun availability varies tremendously around the world, but it's one of the things we can definitely look at. The other big preventable thing is domestic violence. So the more we can prevent domestic violence, the more we'll prevent domestic violence homicide. The other leading cause of mortality related to domestic violence is suicide. There's very strong links where this has been looked at. Domestic violence, intimate partner violence is one of the primary risk factors, if not the strongest risk factors, for suicide amongst women. We find that where we look, where we have the data, suicidality was looked at in the WHO multi-country study, and we definitely find more suicide attempts amongst abused women, more thoughts of suicide, both lifetime and the past 4 weeks. We also find in some interesting analysis that's been done by Hudson and her research team in terms of looking at women's physical security, which can be measured around intimate partner violence, rape, marital rape, and femicide, both in terms of the laws that address those as well as the numbers. And in a wonderful analysis, they found that this physical security for women was significantly associated with the Global Peace Index and also with economic development. Very important findings there that were published in 2009. The other form of mortality that we oftentimes do not count is maternal mortality related to intimate partner violence. Death of pregnant women while they're pregnant or in the immediate postpartum. And in a recent analysis was done in Maryland, we found that maternal mortality was that domestic violence, homicide, was the leading cause of maternal mortality. That's been found in some other studies in the United States. Unfortunately, we don't have good data about homicide and maternal mortality from globally. There's only been a few studies that have done that. So we find that in Mozambique and Bangladesh, where homicide and maternal mortality has been looked at, it's also important there. Obviously, in our low and middle income countries, we have far more other causes of maternal mortality than homicide. So it shrinks in proportion, while in the United States, where we're doing a great deal to address other causes of maternal mortality and have had good success, the homicide becomes a greater proportion. But that doesn't mean that we shouldn't be looking at it. When we're trying to address the Millennium Goals in terms of maternal mortality, we need to look at the homicide deaths also. And they're oftentimes not counted. In a study in India, they found that 16% of all deaths during pregnancy were domestic violence homicide. But they have 41% of recorded deaths misclassified and 70% of maternal deaths unrecorded. So again, we have missing data around this. Infant mortality also associated with intimate partner violence in some countries, and this again is data from the multi-country study. Now, when we look at other causes of health problems related to intimate partner violence, and I don't have long enough to go through all of this, but we are increasing our research in terms of that it's not just intimate partner violence, but it's the cumulative violence exposure that many women experience. Adverse childhood events, child abuse, child sexual abuse, witnessing domestic violence at home, has its own physical health effects, has been shown in the ACEs study in the United States. We also have both physical and mental health effects happening here. We have new research in this country, at least, significantly related, and in some of the other developed, more industrialized countries, significantly relating domestic violence during pregnancy and during the postpartum with postpartum depression. But again, that's seldom measured as a risk factor. Infants that are small for gestational age is also associated with intimate partner violence. Low birth weight, perinatal death, increased maternal and infant complications, gynecological problems, and importantly, and more impressively, the links to chronic disease. The ACEs study clearly showed a link of childhood trauma to early death from cardiovascular disease. And so part of it is what's happening here. What is part of the issues? We also find chronic disease in terms of neurological problems, at least in the United States, linked to traumatic brain injury from intimate partner violence, head injuries, also choking incidents when women are strangled. Much interface with the mental health outcomes that we've for a long time noticed. And part of the issue there is that we're increasingly realize that mental and physical health goes together. You know, that you don't see one without the other, that what happens in terms of violence exposure affects the entire system. Part of that is through immune system alterations, which may cause increased BMI, contribute to chronic pain. All of this physiology is incredibly important if we're going to design appropriate interventions. The HIV link has been fairly well established. There was a recent systematic review and meta-analysis where prospective studies, what few there are, suggest exposure to IPV is associated with incident HIV. The higher quality cross-sectional studies suggest an association between physical violence and HIV, but not sexual violence so much. So it's not necessarily the direct transmission, but the other behavioral effects of domestic violence. And it's beyond direct infection, and we definitely, as we always, us researchers always say, we need more cohort studies, particularly prospective studies. But part of what has not been looked at carefully is, again, this physiology. And one of the things that our work is starting to suggest is that it's not only acquisition of HIV, but some of the physiological effects are increasing women's susceptibility to HIV opportunistic infections, that these effects on the immune system also happen after a woman acquires HIV, and maybe in part some of the issues around women dying more from AIDS. And some women die when they're HIV infected from homicide and suicide. That's also it's also associated with IPV. So we're finding that these multiple injuries that women oftentimes incur through forced sex, forced anal sex, that there's this pro-inflammatory response, that things like STIs increase the inflammatory response, and that makes the HIV virus go through the vaginal wall much more efficiently. So again, we have some of these underlying physiological effects of intimate partner and sexual violence, childhood sexual abuse, that sometimes we're not thinking about. This pro-inflammatory response, this alteration of the immune system, and I used to think that either the immune system was compromised or it was activated. And actually, when you have dysfunction, you can have both things going on with the immune system. So it's like all of us need to take, Immunology 101 when we're looking at these issues and helping get appropriate interventions for women. Again, we have, through the multi-country study, poor or very poor health associated with domestic violence for women all around the world. We have some other relevant studies in terms of the global burden of disease. One of the most compelling ones from Australia for women of all ages, intimate partner violence accounted for almost 3% of the total disease and injury burden for women. And it was more associated with disease burden than things that we always count, like high blood pressure, tobacco, and BMI. Now, the other thing that we have to think about is that intimate partner violence is also associated with hypertension, not that it causes hypertension, but that oftentimes women who have other risk factors for hypertension, if they're abused, have the hypertension be expressed at an earlier age and be more difficult to control. We also find women who are abused smoke at least twice as much as women who are not abused. And again, that's associated all around the world. And then, as I mentioned, some of the BMI alterations that may be in part related to some physiological effects. Poor mental health in Australia contributed 73%, substance abuse 22% to the disease burden from IPV. So here in the United States, recognizing that women who are abused are usually in the healthcare system somewhere, that we're starting to do routine screening and brief counseling, which is an important piece of it. It was recommended by the IOM, and it's been put into effect in the Affordable Health Care Act. And we do have interventions that have, brief interventions that have been shown to be effective. And we've also shown that this routine screening does no harm in clinical trials. So the early identification is what's important. So we can identify abused women before the domestic violence becomes a pattern in their relationship, before it becomes repeated over and over again, before they have multiple injuries, before they have multiple episodes of forced sexual intercourse. And we do have some evidence from around the world that screening and intervention in prenatal care results in decreased abuse and improved health. And we're also doing it in refugee settings in Ethiopia. So it can be done in low resource settings. And so I'm going to skip that because I know I don't have time. But there are other interventions being tested, a decision aid that could be extremely useful, and then also emphasizing a trauma-informed care. Our SAMHSA website has some really good approaches there, with the bottom line that people who are traumatized need some help in what has happened to them, not in terms of treating them differently, stigmatizing them, etc. And that part of our health care for women who are abused in intimate partner relationships not only needs to be around providing more safety, but also providing some healing for that trauma, both physically and in terms of their mental health outcomes. And many of you know the Pigs for Peace initiative, the microfinance with animal husbandry in the DRC that Nancy Glass is doing, innovative kinds of strategies to bring interventions to abused women around the world. The image study was also provided some of that economic development as well as gender norm changes in those communities and individual help for women. And I loved the opening in terms of education for girls. It's been shown to be extremely useful in protecting girls from domestic violence, one of the most important things we can do globally. I cannot help but think of our Nigerian girls in terms of the trauma that they are encountering and what will be needed for them. Thank you.
Thank you so much. Our second speaker is Dr. Sunita Kishore. She is the director of the Demographic and Health Surveys program at ICF International in Maryland. She is also a widely known gender specialist with over 2 decades of experience in conducting research at the interface between gender and health in developing countries. Dr. Kishore has worked for the Demographic Health Survey program since 1993 and has supported the development of special modules on gender-based violence and women's status. In 2006, Dr. Kishore published a widely cited article of survey results in several countries that clearly demonstrate the association of higher risks for pregnancy loss and sexually transmitted infections amongst women who have experienced gender-based violence. Her research also documents the intergenerational impact of family violence. Dr. Kishore, we look forward to your presentation.
Thank you. It's an honor to be here, and it's actually a pretty good turnout for the last session, I guess. As I was introduced, I work for the Demographic and Health Surveys. Many of you may not know a lot about them, but they are, we collect data we've collected data in about 90 countries. Several of them, we have information on domestic violence. I'm going to talk a little about the data that we have on both HIV and domestic violence information out of 5 countries in sub-Saharan Africa. Now, as you heard from Dr. Campbell and those of you familiar with the literature, there appears to be a growing consensus that HIV and domestic violence are linked. In other words, women who experience domestic violence have a higher risk of acquiring HIV, are more likely to be seen to have HIV. So in this, sorry. I guess I'm touching this. Okay. So, but not all research necessarily finds this link, at least not in cross-sectional data. The other problem with some of the research or the comparison across research is essentially that everybody uses different methods, definitions of violence are different, and samples, the kinds of samples being used are different. The other issue is something that, in fact, Jackie also mentioned, which is that there isn't an obvious direct causal pathway between experiencing most forms of violence and HIV. Sexual violence is probably the only one out of the lot where you could say that there is a biological reason, a biological link between the two. But most studies do not find an association between sexual violence and HIV. So for this paper, which has been co-written by a couple of my colleagues who aren't here today, but I speak for all of us, in this paper we examine several different forms of spousal violence, and we hypothesize that a direct effect on HIV is unlikely. Instead, we try to examine whether we could try and explain, first and foremost, we look to see whether there is a relationship, and then we argue that perhaps we would be able to explain it away through other pathways that could potentially link women's experience of violence and their HIV status. So the indirect effects that we think we would be looking at is co-occurring high-risk behaviors of husbands and women's own high-risk behaviors and factors. Now, there are several studies, and I'm not going to go into them in any depth here, but there are several studies that have found an association both between HIV and these kinds of behaviors, as well as domestic violence and these kinds of behaviors. So we look to see how, in fact, these pathways could explain the linkage. So this paper specifically investigates the potential pathways through which the experience of different forms of spousal violence, so we restrict it to spousal violence, may affect women's HIV status, and it asks, are all of the different forms of spousal violence equally and similarly associated with women's HIV status? And if they are not, we ask, for which forms of spousal violence does this association exist? And then we also look into whether the relationship between spousal violence and women's HIV status, whether it can be explained by women's and men's high-risk behaviors and the spousal controlling for the spousal HIV status. The data, as I mentioned, come from 5 sub-Saharan African DHSs, Kenya, Malawi, Rwanda, Zambia, and Zimbabwe. There were many surveys that we could have looked at, but we tried to focus our attention on a recent survey, a survey which had a large enough sample that we could actually detect differences, and a survey in which we had data for both HIV status of the respondents and the woman's domestic violence status. For those of you who do not know a lot about the DHS, the HIV measure comes from actual testing of collected blood and linked back in an anonymous fashion to the interview information. In the analysis, we use pooled data because we were looking at couples so that we would have the husband's HIV status, and that gave us smaller samples. Since not all husbands end up being in the house and therefore interviewed, whatever the woman's sample size is, the couple's sample size tends to be much smaller. We pooled the data, and in addition, and we could go into a lot of the details, but there were 9,385 matched couples in the data. The key outcome that we were interested in was women's current HIV status, and the key explanatory variables that we were interested in were the 5 different forms of violence that we examined. What we did in this paper was we conducted a factor analysis of the data on violence to see what factors emerged, and we got 5 separate factors. One factor which is exactly as we would expect the way DHS defines emotional violence, another one for physical violence, and another one for sexual violence. In addition, we have a whole lot of questions on husbands' controlling behaviors in the DHS, and those controlling behaviors actually split into 2 different factors, one of which we called suspicion because it was things like jealous if she talks to other men, accuses her of being unfaithful, and the other we called isolation, which were the factors around not allowing her to meet her family or her friends, etc. So those are our 5 separate violence indicators. In addition, to be able to examine the pathways, we took data on lifetime number of sexual partners for both wives and husbands, as well as any self-reported STI or STI symptom. For husbands only, we had information on sex with non-spousal, non-cohabiting partners, whether their husband had ever paid for sex, husband's alcohol use, as reported by the wife, and his HIV status. We controlled all regressions, multivariate analysis for the wealth quintile, for information on wealth, on education, urban-rural residents, etc. This table just essentially gives you the range of the violence, each of these indicators across the 5 countries. In the pooled data set, you see that the controlling behaviors are highly prevalent. 59% women report that their husband is suspicious, displays behaviors that we could count as him being suspicious. And we also find that the other largest proportion is for physical violence. 32% of all women in this couples data set reported ever having experienced physical violence. Sexual violence, as expected, is the lowest. All right, turning very quickly to our results. And remember that we are controlling in the different regressions for all of the background characteristics. In the uncontrolled regression, the very first one, you see that in fact these are separate regressions run separately for each kind of violence as an explanatory factor. They're all highly associated with the woman's current HIV status. The second model has controls for all of the second model controls for the background characteristics, and as you can see that in fact, again, sexual violence is not associated. It wasn't actually associated even in the first regression, but the other forms are. And finally, when we introduced all of the pathways that we were talking about in terms of the behaviors, high-risk behaviors of women and men, and controlling for the husband's HIV status, we find that in fact the associations are no longer significant for all forms of violence except for physical violence. And that remains robust and strong even when we try and explain away the relationship with, by introducing the sexual behavior variables. So what are the key findings of this paper? We see that in these data for these 5 countries, which have relatively high levels of HIV, a woman's HIV status is positively associated with her experience of each of 4 of the 5 forms of spousal violence, even when controlling for background characteristics. The only exception remains sexual violence. Sexual violence is not associated with HIV, even with the greater power of a pooled data set. Perhaps there is no association, or perhaps we still don't have a large enough data set with enough women reporting sexual violence separately from any other form of violence to be able to study that carefully. We also find that the high-risk behaviors of husbands and the women themselves are able to explain away all of the linkages that we saw in the regressions with different types of emotional and controlling behavior-related forms of violence. But what we do find is that the only explanation which is not explained away is physical violence and HIV. Even in the full model, this particular relationship remains robust and significant. Now, the potential explanations are that maybe we haven't covered all of the potential pathways. So perhaps there is some other linkage with HIV that we have not been able to model. The other possibility is that in this particular sample, that in fact the association may be running the other way, that HIV is leading to violence. And there we have other data which sort of negates that. But it could also be what Jackie has been talking about and has written about, that physical violence does trigger. This is very sensitive, I'm sorry. Well, doesn't really want to go back. But physical violence does trigger an immunosuppressive response. And that's why you do get a relationship, and that relationship is not necessarily through a biological transfer of the infection, but in fact, your risks of getting the infection at all. And given that, I think we continue to have to focus in on these relationships between what's happening to women on a day-to-day in their households behind closed doors, or sometimes not behind closed doors, and the outcome of greater burden of disease, not only for women themselves, but for societies as a whole. Thank you.
Thank you, Dr. Kishore. Our next speaker is Ms. Alessandra CUGH. She is the Regional Advisor for Intrafamily Violence at the Pan American Health Organization here in Washington. She's worked in the public health field for the past 15 years or so, involved in cutting-edge reproductive health issues that reside really at the intersection of reproductive health and human rights. She holds a Master's of Science in Public Health for developing countries from the London School of Hygiene and Tropical Medicine in the UK, and a Master's in Art Therapy from George Washington University. She's published widely on the topic of violence, including a piece called Improving Health Sector Responses to Gender-Based Violence, a resource manual for healthcare professionals in developing countries. Alessandra, thank you.
Thank you. I'll start off by saying that I have a very bad cold, so please bear with me as I have some water and try to make through the presentation. It's a pleasure to be here. Thank you, Mary, and the organizers of the panel. I'm in really good company. As Joy mentioned, I'm at the WHO's Regional Office for the Americas, and I'm responsible for both violence against women and violence against children in that capacity. And these fields of violence against women and violence against children have grown very much in separate ways over the years, and often folks that are working in one area are not familiar with the evidence in the other. Nonetheless, as both Jackie and Sunita have mentioned, there are many intersections between these two forms of violence. So what I'm going to try to share with you a bit today are some arguments in favor of a more coordinated approach to addressing both violence against children and violence against women. So in the time that we have together, I want to raise some ideas as to why these fields may have evolved in separate and parallel ways. I want to discuss different ways in which violence against women and violence against children intersect. And I will end by suggesting some ways that we could move forward towards greater integration of the fields of violence against women and violence against children. So when I read the evidence and when I think about the intersections of violence against women and violence against children, it seems pretty obvious that there are some very compelling reasons for addressing these issues in a more coordinated way. So I think it's worthwhile to think about why these fields have indeed grown in separate ways. And I think that we can't start this conversation without highlighting that these are areas of work that are highly underfunded in comparison to, say, HIV, malaria, or many other public health issues that we can think of. So perhaps if we had been better funded, we might have reached these conclusions a bit sooner. Since this is not the case, different advocacy efforts and different bodies of research, separate programmatic and policy efforts have been undertaking. And at times, these fields have seemed at odds with one another, with children's rights being pitted against the rights of women. In the US and other countries, for example, women survivors of intimate partner violence have been known to be blamed for allowing their children to be exposed to such violence. These two issues also compete for limited funding, and those working on violence against women often fear that a focus on violence against children may undermine the agenda. However, as the fields of violence against women began to emphasize primary prevention, and as research on the risk factors associated with both the perpetration and the victimization of violence against women has grown, we've come to realize that in order to prevent such violence, we have to start very early. And this necessarily involves preventing children from being exposed to any form of violence in the first place. So in short, technical, financial, and political reasons have resulted in the existing distance between these two areas of work. So let's start by reviewing what we mean by intersections. There are multiple ways in which violence against children and violence against women are linked. Both types of violence share common risk factors. They also tend to co-occur in the same household. One type of violence may be a risk factor for the other. They may result in similar consequences. And furthermore, we know that violence against women starts early, and that there is a particular age group that straddles the definitions between violence against children and violence against women. So I'm going to briefly talk about each of these forms of intersection. Let's start by reviewing some of the shared risk factors. So this slide shows us selected risk factors associated with the perpetration of both violence against children and violence against women, according to the sociological model that many of you are familiar with. I'm not going to go into each of the risk factors on this slide, but it is clear that there are multiple risk factors that are associated with perpetration of both of these manifestations of violence, including, for instance, if we look at the individual level, having been exposed to violence directly or indirectly, using alcohol and drugs. At the relationship level, male dominance in the household, economic stress and poverty. At the community level, gender and social inequality, norms about privacy in the family. And at the societal level, lack of adequate legislation or improper implementation of existing laws. Social norms that consider the use of violence, including physical punishment, to be acceptable, and the socio-economical, legal, and political disempowerment of both children and women. It follows that if we're able to modify these factors, we may be able to prevent both violence against children and violence against women, and I would argue possibly other forms of violence as well. An important similarity in the perpetration of physical violence against women and children is this shared logic of the use of physical punishment to, quote, correct perceived transgressions. This shared logic deems that beatings only qualify as mistreatment if they're especially severe or not for a just cause. Disobedience or failure to fulfill certain expectations is a major justification of the abuse for both women and children. In the next few slides that I'll share with you, they include data from a recent comparative analysis of population-based data from 12 countries in Latin America and the Caribbean that was carried out by PAHO and the CDC with the support of Sunita and her team. I won't be going into the details of this report, but I wanted you to be able to understand and interpret the data appropriately. So the data that we are analyzed come from both the demographic health surveys that Sunita has mentioned and also the reproductive health surveys, which are nationally representative. The data is cross-sectional and consequently does not allow us to establish causality. However, it does allow us to show some consistent associations through bivariate analysis. A lot more detail on this report and this data is available online in the report whose cover you see on your screen. So in this slide, we're looking at the number of women aged 15 to 49 in 4 Latin American and Caribbean countries who agree that wife beating is justified according to 5 different reasons. So if you look at the bars from left to right, we have going out without telling the partner, is suspected of being unfaithful, disobeying the husband, neglecting children or housework, and refusing to have sex. And although this data comes from Latin America and the Caribbean, it is consistent with data from other regions in the world. And I think it's interesting to note that in the case of violence against women, many of the justifications for physical punishment are linked to gender expectations. In other words, the expectations that women fulfill what is perceived to be their responsibilities as women, wives, or mothers. In this slide, we see data on the acceptability of the use of corporal punishment to discipline children. Interviews were conducted with mothers, fathers in 9 countries globally. 17% of parents overall believed that the use of corporate punishment was necessary to rear children, with significant variations across countries, as you see on your screen. So we've just reviewed some of the common risk factors. Let's now look at the co-occurrence of these 2 types of violence. And co-occurrence can be loosely defined as violence against women and violence against children taking place during the same time within a single household. Although considerable more work needs to be undertaken to improve the measurement of co-occurrence, particularly in low and middle income countries, studies from the US and Europe suggest that child maltreatment and intimate partner violence co-occur in about 6% of families in the general population, and that child maltreatment is present in about 40% of families where intimate partner violence is taking place. In this slide, we see a bivariate analysis comparing the proportion of women who say that children in their household are punished with hitting, beating, spanking, or slapping, according to whether they reported experiencing physical or sexual intimate partner violence ever, these are the dark purple columns, or whether they did not report intimate partner violence, the light purple columns. In all surveys, the proportion of women who reported that children in the home were harshly punished was significantly greater among women who reported intimate partner violence ever compared with those who didn't. I do want to note that these surveys did not ask who was punishing children, so we don't know from this data whether it was the mother, the father, or someone else in the household. What we do know is that in households where IPV is taking place, there's a greater likelihood that children are punished harshly. There is compelling evidence from a wide range of high as well as low and middle income settings documenting that children who are exposed to intimate partner violence or who are physically abused themselves are more likely to use violence in their relationships as adults. This is often referred to as the intergenerational effects of violence or the transmission of violence. And here I would like to make a caveat to say that not all children who are exposed to violence go up to perpetrate or to be victimized. In fact, the data suggests that only a minority of them do. However, early exposure to violence does seem to be a consistent risk factor. So we are now looking at the percentage of respondents who reported physical or sexual intimate partner violence according to whether they reported that their mother was being beaten. These are the dark purple columns, or whether they did not report that their mother was being beaten in light purple. In all surveys, the proportion of women who reported physical or sexual intimate partner violence was significantly greater among women who reported that their mother or stepmother was beaten compared with those who did not. And although we're looking at data for women, other studies have shown a strong association between boys' exposure to violence against their mother and later perpetration of IPV. The evidence also shows a strong association between being exposed directly to physical and/or sexual violence in childhood and later victimization for girls and aggression for boys. Violence against children and violence against women also result in similar consequences that may require related responses and services. So let's look at that for a bit. This slide comes from the Together for Girls initiative, which Jackie also mentioned in her slide, and specifically from the Violence Against Children survey implemented in Swaziland, and shows the association between childhood sexual abuse and selected health conditions among females aged 13 to 24. Through the adjusted odds ratio, we see that exposure to sexual violence in childhood increases the odds of several health conditions that are also associated with violence against women, including HIV, pregnancy complications, alcohol use, unwanted pregnancy, depression, and suicide, among others. Another important intersection between violence against children and violence against women is that the evidence tells us that violence against women starts early. So in this slide, also from the PAHO CDC analysis, we see the association between age and the prevalence of partner violence, either physical or sexual, in the past 12 months. What we're looking at is a set of 5 columns for each of 12 countries, where the columns from left to right represent increasing age groups. So the black columns represent women aged 15 to 19, then 20 to 24, 25 to 29, and so on. In the majority of countries, the prevalence reported by women in younger age groups was almost twice as high as the prevalence reported by older women. So we know that victimization starts early, and we also have data showing that perpetration of violence may start early as well. Data from South Africa, obtained through interviews with men, showed that of those surveyed, 28% said they had raped a woman or girl, and 3% said they had raped a man or boy. Of these, 73% said they had carried out their first assault before the age of 20, and 16% said they had carried out their first assault between the ages of 10 and 14. This data urges us to intervene early with both boys and girls. So now there's an age group that seems to fall within a gray area. The UN defines a child as anyone under the age of 18. Meanwhile, virtually all studies on intimate partner violence against women define a woman as an ever-partnered female aged 15 or older. Therefore, by definition, girls who are between the ages of 15 to 19 should be of concern to both those who focus on violence against women and violence against children. However, in practice, adolescent girls sometimes fall through the cracks. Adolescence, nonetheless, presents not only a period of great vulnerability to violence, but also a great opportunity for prevention among both boys and girls. So on this note, let's think about how to move forward. First of all, we must work to transform whole institutions. At a very basic level, we need to make sure that services are prepared to provide age-appropriate care, including post-rape care. Second, the identification of a child or adult female victim should generate a multifaceted response by systems of care. If a woman is receiving care for intimate partner violence, providers should inquire about her children and engage appropriate services. Likewise, if a child is receiving services in response to violence victimization, their mother should be engaged, screened, and provided care when appropriate. Antenatal services may be particularly suitable as an entry point to jointly address violence against children and violence against women. And finally, we must ensure that schools are safe space and that sexuality education incorporates discussions on gender and power dynamics and violence. Let's also look for opportunities to develop joint prevention efforts, including by examining existing programs that could be expanded to this end. For instance, with some exceptions, home visitation programs have not been traditionally designed to prevent child maltreatment, but they could be strengthened by integrating discussions in skills building around child discipline, assessing for child maltreatment, as well as intimate partner violence. Existing parent training programs, on the other hand, could be revamped to integrate a focus on gender, socialization, and the more equitable treatment of boys and girls. And finally, if exposure to violence in childhood is a strong predictor of later victimization and perpetration, it is imperative that we develop specific interventions that target those children who have already been exposed to violence. So I started this presentation by addressing some of the issues why these fields have grown in separate ways. And I think that as we seek greater coordination between these fields, we would be wise to tackle head-on what some of the perceived or real risks of a joint agenda might be. I think, first of all, we need to agree that not everything needs or should be integrated. There may be very valid reasons for interventions that focus exclusively on violence against children or violence against women. So moving on to perceived or real risks, from those that are working on the violence against children field, there may be a concern about whether children's voices will be heard and whether services will be adequately tailored to meet the needs of children. And those working on violence against women may wonder whether children's rights will take precedence over women's rights and safety. And we must also think about the intersections with other forms of violence, such as youth violence, which I have not addressed. And I think that these are very valid concerns that we need to keep returning to them and ensure that we are moving forward in an ethical and balanced manner with a single and shared goal, that every child, woman, man, every child, woman, and man has a right to be free from violence of any kind. Thank you so very much.
Thank you so much, Alessandra. Well, last but not least is our panel leader. And many of you, I'm sure, know Dr. Mary Ellsberg, but for those of you who don't, she is the director of the Global Women's Institute and professor of global health at George Washington University. She has more than 30 years of experience in international research and program work. Before joining George Washington University in August 2012, Dr. Ellsberg served as Vice President for Research and Programs at the International Center for Research on Women. Her deep connection to these issues really emerges not only from her academic work, but from the fact that she lived in Nicaragua for nearly 20 years, leading public health and women's rights advocacy there. She was a member of the core research team of the World Health Organization's multi-country study on domestic violence and women's health, and is co-author of the WHO PATH publication, Researching Violence Against Women, a practical guide for researchers and activists. And on a personal note, it is a delight to get to know you, Mary. Thank you so much. Looking forward to your talk.
Thank you so much, Joy. I am acutely aware that I have the dubious distinction of having the very last talk of the conference, which is a big responsibility, and I thank you all for for hanging in to the very bitter end. First of all, I'd like to acknowledge my co-authors on this paper, both from the George Washington University and from the World Bank. And I'll just say a few words about the progress we've made. You've heard already from Sunita and Alessandra and Jackie. In the 20 years since the Beijing Conference on Women really put violence against women and girls on the international agenda and urged governments to collect better and more data on the causes and the prevalence of violence against women, we've made huge progress, as you can see, evidenced by my colleagues. We now have data, hundreds of studies from over 80 countries on the prevalence of both intimate partner violence and non-partner sexual assault. And we know from recent papers published in The Lancet that about 1 out of every 3 women experiences physical or sexual abuse by an intimate partner in her lifetime, and about 1 out of 7 women experience non-partner sexual assault during their lifetimes. And in the paper that we received, the Lancet, the journal with the global burden of disease studies, we also saw that intimate partner violence is now seen as one of 25 of the major risk factors for disease. There's something a little odd there. We're just behind processed meat, and that's not clear what that means. I think what it means is that we haven't finished analyzing our data. I'll let you think about that for a minute. And we have much more understanding on the risk factors for violence against women, both at an individual level as well as community and society level. Where we are still pretty far behind is understanding what we can do to reduce or prevent violence against women and girls. And although we have made some progress, we're still really in the infancy stages in this area, and I think this is really the big frontier that we need to address in the next 20 years. So in order to understand the current state of the evidence on what works to reduce violence against women and girls, the Global Women's Institute at GW partnered with the World Bank to carry out a systematic review of reviews that would allow us to summarize, analyze, and assess the quality of individual systematic reviews on various interventions that have been implemented throughout the world to reduce violence against women. Using this methodology, we really sought to answer some of the following questions. What are the interventions that are most evaluated, and where are they being evaluated? What seems to be working and what isn't working? Where is the evidence strongest and for which types of violence? What are the lessons for policy and practice? And especially, what are the persistent gaps in knowledge that we still need to address? We classified in general the different forms of violence against women and girls into 5 areas. intimate partner violence, which is where we have the most data, and that includes physical, sexual, or emotional abuse by a current or former intimate partner. Non-partner sexual abuse, which includes rape, sexual assault in conflict areas, sexual harassment in school or in workplaces. Child sexual abuse, which is any kind of a sexual assault where the survivor is less than 18 years old. Harmful traditional practices, which we defined as any incident of violence perpetrated in accordance to local, social, cultural, or religious values. And that would be including, for example, female genital mutilation or cutting and child marriage. And then finally, trafficking, which we defined as violence experienced by someone who is recruited or harbored by another through the use of force for the purpose of exploitation. So just to summarize very briefly this whole review process, we started with about 3,000 articles of both peer-reviewed journals and by consulting experts and using gray literature. And we came up with 58 systematic or comprehensive reviews that address different forms of violence against women and girls. Out of these, we found 290 individual impact evaluations. And those could be looking at either efforts to reduce violence against women, which was our primary outcome, or to change and improve attitudes or norms that support violence, which was our secondary outcome. Out of all of this, we found 84 evaluations that were done using rigorous methods, either experimental or quasi-experimental designs, and that addressed our primary outcome of reducing violence, and for which we had data available to assess the quality. And finally, out of the 84, we found 20 effective interventions using these criteria. So 20 is a lot more than we had a while ago, but still 20, from 3,000 to 20, it's a pretty steep curve there. Now I'm going to talk a little bit both about the 84 evaluations that are in our general sample and the 20 that were most effective. So the first thing we found when we looked at geographic distribution, almost 80% of all of the studies came from 6 OECD countries that comprise 6% of the world's population. That in itself, maybe not too surprising, but pretty stunning in terms of giving us a sense of how much we're missing in terms of what we know about lower middle income countries. We also found, looking at primary versus secondary prevention, we found that the majority of the studies were addressing secondary intervention as opposed to primary. So that means that they were either targeting male perpetrators or women who had already experienced some sort of violence with the aim of reducing either recidivism or re-victimization. The remaining interventions focused on primary prevention and targeted individuals or populations whose history of violence was unknown prior to recruitment in the study. So these interventions are the ones that really seek to prevent violence from occurring before it begins among those who had not experienced violence, and then to reduce reoccurrence among those who had already experienced it at the time of the study. So interestingly, we find there is a difference in the proportion of primary versus secondary prevention interventions in the low and middle income countries compared to high income countries. So in the high income countries, primary prevention is barely a quarter of the total interventions that we saw there, which were 66. In low and middle income countries, almost 90% of the 18 studies that we have in our sample were directed towards primary prevention. Now, in terms of the kinds of violence that were addressed, not too surprisingly, almost 2/3 overall of the interventions were addressing intimate partner violence. Another 20% was non-partner sexual assault, and 11% harmful traditional practices. And in this case, we only found studies on female genital mutilation and on child marriage. But again, if you look at the difference in distribution between the high income and the low and middle income countries, there's a big difference here also, where we see that 3/4 about of the high income countries are focused on intimate partner violence, and then another quarter on non-partner sexual assault, whereas in the low and middle income countries, a little over half of the studies are actually focusing on harmful traditional practices. We found no studies meeting our criteria meeting our criteria related to trafficking or child sexual abuse, which is important. Among the studies that were on non-partner sexual abuse, most of them addressed sexual assault prevention or date rape, and these were mostly among American college students. So that's also sort of a particular bias of these studies. And as I said, all of the studies on harmful traditional practices dealt with either female genital mutilation and cutting or child marriage. So now I'm going to say, I've said a little bit about the overall sample. Now I'd like to say something about effectiveness. And again, I need to point out these numbers are small. It's hard to, there's a lot of variety in the different kinds of interventions, and yet I think there still are some important messages here for us. So out of the 84 studies altogether, about a quarter of them had one or more positive effects. So they could have mixed effects, but they had at least one positive result that reduced violence. However, if you look at the proportion of effective studies between the primary prevention and the secondary prevention, it's really interesting. Over a third of the primary prevention studies were effective, whereas only 16%, about less than 1 in 5 of the secondary prevention studies showed positive results, any positive results. Again, if we look at effectiveness by the types of violence addressed, we found that almost half of the studies that were addressing harmful traditional practices had some effective effects, compared to about a quarter in intimate partner violence, and only 1 out of 17 of the studies on non-partner sexual assault had positive results. When we look at the interventions, and according to whether they're targeting men, women, or both, here we find overwhelmingly that the interventions that are targeting both men and women, and these tend to be primary prevention kinds of programs, they're the ones, almost half of them have positive results. So they're by overwhelmingly the most effective. The least effective ones are the ones targeting only men. And the large majority of these are batters interventions. So out of 18 interventions that were focused specifically on reducing recidivism among batters, male batters, only 1 out of 18 showed any kind of positive results when using a quasi-experimental design. And part of the problem with these studies was that we left out many, many more studies that didn't meet our criteria for rigor. The women-only studies, about a quarter of them were positive, and most of these take place in the context of health services and involve pregnant women who are screened for violence during prenatal care, and some of them were mentioned by Jackie earlier. And although it's important to say that these studies have a host of positive outcomes for both women and their offspring, such as decreased depression, lower stress, greater knowledge, use of services, only about a quarter of the interventions actually report decreases in violence. Before I end this, I do want to say that we did find some evidence in primary prevention programs that were targeting men specifically, but looking more at broad behavior and gender norms, we did find some evidence of effectiveness there. So in my last couple minutes, I know you're wondering, what do these programs look like? It's hard to understand just seeing the numbers and the bar graphs, what we're really talking about. So I'm going to give you a few examples. One of them was actually presented already by Jackie, and it's the intervention with microfinance for AIDS and gender equity, the IMAGE study, which was carried out with rural women in South Africa. And basically, women were provided with it was a cluster randomized trial. They were provided with microfinance, but also a lot of educational activities and community mobilization around HIV awareness, around cultural norms, and around violence against women. And they had some pretty stunning results. After 24 months, they found that 50% of the women who were participating in the intervention group, that there was 50% less intimate partner violence in the intervention group compared to the control group after 24 months, which is really a huge effect size. Another really important one is SOS, and you'll be hearing more about it because the London School of Hygiene and Tropical Medicine has also just carried out a cluster randomized trial that is in publication right now. But this is a really exciting program. It's been replicated throughout Africa, also in Haiti. It's a community-based program organized by the group called Raising Voices in Uganda. It emphasizes prevention by focusing the attention of men and women on the benefits of nonviolence and gender equity. And they look more at a deeper analysis of the causes of violence and gender inequality and the impact of violence on families. And one thing that I think is really important about it is that it talks about how violence doesn't just hurt women, but also reduces trust and respect among family members. And it stresses it doesn't treat men as bad or as the cause of the problem. It talks about the causes of violence being an imbalance in power between men and women in families. And this seems to be a concept that people really can get around and think about without feeling very defensive. One last program I want to mention, and probably most of you have heard of this model. It's the Community Empowerment Program developed in Senegal by the NGO Tostan. And that's also been replicated in many countries in sub-Saharan Africa. And it uses community-based education programs that address a variety of issues, including health, literacy, and human rights. Through these programs, villagers identify priority issues for community action, and both FGM, child marriage, and domestic violence have emerged as key issues. In fact, these community conversations have led to over 7,000 villages to date having done public pledges to either abandon FGM in their communities and child marriage, and to encourage neighboring villages to do the same. So in our sample, we had a cluster randomized trial of the program in Senegal that found that in the intervention villages, women reported significantly less violence within the last 12 months, and the mothers of young children were much less likely to report that their daughters had undergone FGM. And it's particularly noteworthy that the effects were seen not just among the women who actually participated in the group education, but in random women throughout the community, showing that the diffusion effects of this program are also very great. So just to sum up, despite all the shortcomings of the current evidence base, we have seen some promising trends. We've shown through several studies that it is possible to prevent violence with pretty large effect sizes over a relatively short period of time. The most successful primary prevention interventions used multiple approaches, such as group training, combined with livelihoods and social communications, and they engaged with multiple stakeholders over a prolonged period of time. They also addressed underlying risk factors for violence, including social norms around gender and the acceptability of violence. For programs responding to violence, we found that women-centered programs were much more effective than batterers interventions, and that interventions that aim not just to provide services, but also to empower women were the most successful. Now, clearly from this, we have some good news, but the bad news is that we're really just beginning to compile this evidence, and we need to have a much greater investment, both in innovative preventive strategies, emphasizing primary prevention, and much greater investment in evaluation of what works and what doesn't work, and particularly from the Global South. One thing that I think is worth noting is that we saw most of the work in the Global South based on harmful traditional practices, whereas we know from the global burden of disease that intimate partner violence is the most common and severe problem that most women face. And so clearly we need to be doing more around intimate partner violence as well. We're missing evidence on so many other important forms of violence, such as trafficking, sexual violence in conflict, and child sexual abuse. We have almost no evaluations targeting indigenous communities or older persons, and very few that look at violence against women and girls that are either mentally or physically disabled. And finally, we need to develop more standardized indicators and methods to enable us to compare program effectiveness across settings. But most of all, as I said before, what we need is greater investment in primary prevention programs, and particularly community-based programs that address the underlying structural drivers of violence. Thank you very much.
Thank you so much. Is this on? Is this on? There we go. Thank you so much. Clearly, we needed, I think, about a good 15 more minutes to be able to have a wonderful discussion to follow this panel. We tried to do a lot in a very short space of time, and can we take a few questions? That would be wonderful. Thank you so much. So please, if you have questions, please come to the microphones. I just have one request. If you can keep the questions as short as possible, I would be most grateful. Go ahead, sir.
Thank you. This is a wonderful panel. We all wish we had more time. I had a question for Mary, but it ties to Alexandra's presentation, which is on primary prevention. Were any of the studies addressing with early and mid-adolescence, addressing power relationships, gender roles, the education of younger children, and those types of education? Were any of those on the education level as far as any of the evidence-based studies you highlighted?
Yes. Particularly the programs that are addressing child marriage, because one of the major strategies for reducing child marriage is keeping girls in schools. And so there were several different approaches, and a few of them were successful. Some of them involved working with girls directly, small groups, sometimes village savings and loans programs, but a lot of them talking about their rights and the importance of staying in school. Others combined this either with school incentives, conditional or unconditional cash transfers, school uniforms, and some programs that had incentives like Ethiopia program that gave girls' families a goat at the end of, if they were not married by the end of the program. But definitely there are more and more school-based programs.
Okay, wonderful. Now I see we have 1, 2, 3, 4 people here. So I'm going to start with the gentleman on my right back here, and then I will go to the 2 gentlemen on my left, and we'll finish with you, ma'am, in the middle. Sir.
Hello. My question is what's the current state of evidence of violence against female sex workers, and will legalization of prostitution lead to, and what's the potential impact on violence against female sex workers? Thank you.
Do you want to handle it? Go for it.
It's on. Unfortunately, relatively small, and we are looking at some of that in the United States. There's some ongoing studies looking at violence against sex workers. In terms of homicide, I would love to be able to do some studies of homicide of sex workers, because they are usually get categorized as unknown perpetrator, and they don't even get counted. Even here in the United States, where we do a pretty good job of counting bodies and trying to determine who the perpetrator is, let alone around the world. So from all the way from homicide down to other forms of violence against sex workers, it's pretty much a vast unknown unless somebody else knows much, but needs to be done.
Thank you. Sir.
Yes, thank you very much. Excellent presentations. I'm curious about the solutions, and I noticed in one of the preventive solutions where you need to have both men and women involved in the preventive interventions. But again, I think it was mentioned yesterday in one of the panels, there were only men on the panel, and here there's only women on the panel. And so where are the men who are assisting and doing this type of research and intervention as well? And in particular, in the countries where you're doing the research and it seems like we're focused on the perpetrators as primarily being men. And then a second type of thing is the other religious, cultural, social aspects of it internationally, where on the map where you showed the majority of the areas is like the Middle East and Northern Africa where the perpetration is going on. What's the social, cultural, religious aspects of that in those traditional interventions that could be addressed? So, thank you.
Okay, who would like to tackle these questions?
So I'll take the first question, and then somebody else will take the second. There are a number of groups of men, or focusing on men, that exists not only in high-income countries, but also in low and middle-income countries. You have groups like the White Ribbon Campaign, Men Engage, that started to work primarily with young boys, adolescent boys, and now we're working with both boys and girls. So there's a lot going on. I think that we still need a lot more, but there's a lot going on. I think the challenge is how to make sure that these groups work in a more integrated way as well.
And also that the interventions, those programs are evaluated is the other thing that we don't have as much on. Mary?
Yeah, and with regard to the distribution of violence, I wouldn't say that it is largely in the Middle East part of it. In fact, most of the data that we have shows that it is very, very widely, and we work in almost the entire developing world. It's distributed all around in all the continents, and also that in fact you cannot easily assess the countries, or you cannot easily sort of predict the countries in which you're going to get reporting rates as high as 60% of women saying that they have experienced violence. So I would not sort of in any way characterize that there are only certain regions where violence against women is found. In terms of child marriage or in terms of FGC, yes, there would be, because these are cultural practices as distinct from, stuff that goes on in a lot of different households across the world.
Sir.
Roberto Nang, Uniformed Services University. I want to thank the panel for their very enlightening, sharing their enlightening epidemiologic analysis and their preventive interventions. Specifically, my question is relating to the epidemiologic analysis. I was wondering if you all had controlled for, in terms of looking at the rates of violence, what were the effects on the religions of the partners that were involved, male, female, whether they were from a religious Buddhist background, Christian, Muslim background, or their socioeconomic status, controlling for their socioeconomic status, or the educational attainment of the partners that were involved.
Okay, so who wants to take that?
We can do this between us. Okay. The WHO data do not have information on religions and religious practices, and I don't know if DHS does. When we don't control in the prevalence figures, we don't control for anything else, we don't standardize it, but in the risk factor analysis, we have included socioeconomic status, and usually that and lower socioeconomic status in general is associated with higher risk. And higher education, having completed secondary school, is one of the factors for women that lowers risk. I'm not aware of any religious analysis.
I did, in the study that I presented, we did not control for religion, essentially because we had a large number of countries in there. But if looking, the DHS data are always presented in bivariate analysis at any rate. We do give information on distribution by religion within that country. And again, we don't know about religious practices. We do know about what religion that person, or ethnicity, religion and ethnicity. We have information that you can look at the data. You can use that information to look at the data. But what is in fact important, I think, is that this is not something, again, that you can just pin on a single religion, because in fact, you do find it fairly uniformly distributed across religions. It is true that education has a huge effect, and we don't always know whether that is a difference in reporting and to what extent it might be a difference in reporting, and wealth does have an effect. There are some other factors, particularly something that has already been mentioned, and that is whether you come from a family in which there already was violence.
If there are political sensitivities associated with looking at religion, I can understand that, but it would seem to make sense that religion potentially impacting the moral values and also family values would be something to look at.
Can I just say, though, that just about most religions, there are followers who can use their religion to support using violence against women. So I'm not sure that you would find very many religions where you could say that, that is absolutely protective for violence.
Last question, ma'am. Hello, Teresa Townley from Creighton University. Again, thank you for a wonderful panel. I am wondering what your thoughts might be on integration. We know there's a lot of large-scale projects out there that involve community engagement, such as OV control or malaria control, to name a few. And whether it would be a good idea or it would be quite detrimental to involve these types of discussions in these already ongoing large-scale projects.
Thank you. Mary, do you want to take that?
I have opinions on that.
Okay.
I think it's a great idea. I mean, in public health, we have been doing, group education around breastfeeding and immunization and so many other issues successfully, and malaria and bed nets. Why shouldn't we be talking about gender inequality and violence and how that impacts people's health? So I think it has to be done carefully, and this is a sensitive issue where if you're asking people to talk about their own experiences of violence, for example, you're potentially putting them at risk of retribution. So it would have to be done carefully, but I think it's absolutely what we in the public health community should be doing. And in fact, the one point I'll make is the image study. That was basically using, as a platform, microfinance programs as a way of being able to talk to women about violence, and it was hugely successful. And I think that we could be doing something very similar in many of our public health programs.
Anybody? Well, thank you so much. First of all, thank you to the CUGH leadership team for putting this particular topic on a plenary session panel and for giving us a little bit of extra time to have some Q&A with the audience. And thank you to the panelists for such a wonderful, stimulating presentation. I know I learned a great deal, and I think you've given us a lot of food for thought on how to move forward in terms of where we need more research, as well as where there can be some policy action, some social action, and how we can fit ourselves into those various lines of inquiry and action. So thank you very much, and we look forward now to the final closing session.
Well, that was quite a terrific session. You don't get people to stay this late in a meeting without a fabulous session. So, my very last set of responsibilities as chair of the board of CUGH is right now. And I'm going to do two things. First of all, I'm going to ask our conference chairs and Tim to come on out here. And where's Keith? You guys are supposed to join me out here. And then Dalal or somebody is supposed to give me a few things. All right, good. So the first thing I want to do is say that a conference like this obviously doesn't happen without a huge amount of work on the part of many, many people. Tim, in just a minute, is going to go through some of those many thank yous. But I want to thank you all and the other folks who were here for most of this conference, because no matter how hard we all worked on this conference, and I can tell you we worked pretty darn hard on this, it would not have been anything without your participation, your engagement, and I personally learned a lot from being here and connected with a large number of new colleagues and friends. I hope you did as well. So the first thing is a thank you to all of you, and especially you guys who are still here. So the second thing is that it's time for me to pass the baton or the gavel to our new board chair, who is the good Dr. Brewer. And I realized in thinking about this a couple of things. One is that, both torches and gavels sort of run the risk of unintentional or intentional injuries, so those are really kind of gauche. The second is that we do need a tradition now that we're 5 years old, right? 5 or 6 years old. And so
we need a TSA-approved tradition.
Yes. Well, we actually have found a TSA-approved tradition. There are actually two parts to it that will go to you, for you then to pass on to the next chair. And, I realize that the most important thing for a chair is to have a very clear vision and sense of direction. I think you have both of those, but just in case, and for future generations. This is our replacement for a torch or a gavel, and it's supposed to help you with even further clarity on your vision and your sense of direction. So. Wait. There's another part to this. So the other thing you need, in addition to that I found, was a little bit of magic. Okay? And so. Don't you think? It's good, right? Good tradition. All right. So you be sure to pass this on.
Which one am I passing on?
You're passing both of them on.
Oh,
After 2 years.
Bummer, I like the hat.
Well, maybe you can keep it. Plus, there'll be a new one in fashion then.
So as a former sailor, I actually know what this is and what you do with it. So I have 37 seconds because I have a firm belief that you always finish on time. So first, to our two co-chairs, Michele and Jim, this would not have been possible without you. We owe you so much. We're going to give you so little, but thank you very much anyway. All right. Where are they? There we go. There you go.
We need this. We need this.
Thank you very much. Please don't shake that. Keith Martin, you have done so much for us in so little time. We're incredibly grateful. We also, and you don't have to get on an airplane, so you can actually keep this one. Thank you so much.
Michele, you give it to me. I'll take care of it for you. Thank you.
Dalal, we had one more, is that correct? One more, and this is to actually the entire CUGH office. Dalal Najjar, you haven't met. She's our Director of Operations, pulls everything together. Karen Lamb, our Program Manager, without whom we couldn't do anything. Catherine, our wonderful intern, and Jillian Morgan. So we should have gotten 4 of these. We only got 1. I apologize for that. But thank you very much. Have a very safe trip home. Oh, yes. Come to Boston, March 26th to 28th, 2005. Thank you again. All right.
Bring the whole team in here.